Understand benefits of and give examples of bedside two-person caregiving. And we are going to return demonstration of proper positioning, techniques to optimize comfort and postural alignment, describe various forms of positive pre-feeding activities, identify ways to support breastfeeding in the hospital, understand the importance of the first feeding, describe oral aversion and identify stress signs seen at the bedside, and also describe what it means to know the flow. Can you hit the next one?
Oh, sorry.
You're good.
I'm like looking at it.
So what is neurodevelopment or neuroprotection, and why does it matter? So neuroprotection refers to the relative preservation of neuronal structure and function. So during development, we're really laying down these neural pathways for these babies. So something that we always think about as therapists are neurons that fire together, stay together, the good, the bad, and the ugly. So every interaction that you have with these babies, you're really laying down the neural pathways with each touch and interaction.
Okay, I feel like I'm far back.
I know.
So I'm gonna switch.
I'll switch it, yeah.
Okay, don't we love this picture? I do. So what is neurodevelopment? Neurodevelopment is the brain's ability to develop neurological pathways responsible for normal functioning. So it's the brain's ability to learn, to focus, to develop memories and social skills. Everything a person does on a daily basis, whether you're listening, you're watching, as a child you're playing, you're reading, writing, or talking, all of those things are going to contribute to the neurodevelopment of the brain. So I'm going to shift gears a little bit and get kind of sciencey, but I'm going to talk to you about some of the research that is pretty important to this kind of field, if you will. So this study, Changing Mortality in CHD by Carey et al. In 2010, looked at characterizing trends in all-cause mortality in patients with CHD. So historically, where we've been at in the past is that a lot of infants with CHD died in early childhood. So the focus was on decreasing mortality and really working on the surgical techniques and things like that to help these kids survive their surgery. So over the past 4 decades, there's been great strides that has been done, and virtually now every child that has a complex congenital heart disease has basically a surgical outcome or a surgical option, and they are surviving. So recent population prevalence studies show us that our kids with CHD are surviving into adulthood. So they've shown us that the number of adults with CHD mirrors that of children with severe congenital heart defects. So on this graph, I wanted to explain it to you. When you look on the left, that is the population that they looked at from 1987 to 1988. And then on the right, they looked at people with CHD from 2004 to 2005. So when you look at the bottom, you're starting at below 1 year old, and then the ages go up vertically. Are you with me? Understanding the graph? Okay. So on the left, in 1987 to 88, 49% of deaths were between the ages of 1 and 20. And then when you go over to the other side, you go to 2004 to 2005, only 9.3% of deaths occurred under the age of 20. Also in 2004 to 2005, although the deaths of infants from 0 to 4 is more frequent than a little bit later in childhood, it mirrors what the normal population was in Quebec. That's where this study was done. So the other thing that's notable is that in 2004 and 5, you can see that black line. That's the normative age of death of the normal population. So people with CHD are mirroring the death pattern, if you will, of normal people without. So with that change, the focus has to change from mortality to morbidities. And what are we going to do about these morbidities that we're seeing? So I'm going to do my best at describing this. How many of you have heard of the Boston Circulatory Arrest Study? It's pretty profound. It's a landmark study that it's a world-renowned study that really is the driving force behind a lot of neurodevelopment in the cardiac population. So this study enrolled 171 infants between 1988 to 1992, and they chose children that had dextrocardia transposition of the great arteries, either with an intact ventricular septum or a VSD, and they were all undergoing an arterial switch operation within the first 3 months of life. It was a single center randomized trial at Boston Children's, and the two treatments, they looked at the two different surgical techniques. They compared total circulatory arrest, or TCA, and low flow cardiopulmonary bypass. So you might ask, well, why did they do that population? Because we always think of HLHS as our high risk, right? So in a study, they chose transposition because those kids have a lower operative mortality. They have fewer extra cardiac anomalies, like if you think about your TOFs that have DeGeorge or a lot of the other cardiac defects that are paired with other things. They wanted to eliminate that as a risk factor, as an outlying factor, I guess you could say. Typically, kids who have TGA, like, sorry, so it's not going to hit. They typically have their first surgery in the same time. So that was another thing to try to keep the population as homogeneous as possible. Also in this surgery, they have fewer post-operative hemodynamic abnormalities, which is a big factor. So they took this group of kids and then they were going to look at them neurologically and developmentally, perioperatively at 1 year, 4 year, 8 years, and 16 years. Next. So what did they measure? They did 48 hours of continuous EEG post-op. They did the Bayley Scales of Infant Development, both the psychomotor component and the mental developmental index. They did the Fagan test of infant intelligence, which is visual recognition and memory. They did a neural exam, and they rated it as either normal, possibly abnormal, or definitely abnormal, and they did brain MRIs. So results at 1 year, they did the Bayley, and what they found was that the psychomotor development part piece was significantly lower in the total circulatory arrest group. When they did the mental developmental index, there was no significant difference between those two groups. But both the MDI and the PDI scores were both significantly lower than the normal population. They didn't have a control, they just did it to the normal population. When they did the Fagan test of infant intelligence, 21% had scores indicating failure, but there were no significant differences between one versus the other. So moving on to 4 years, they looked at them when they're a little bit, they're in that preschool age, right? So performance was rated as below normal compared to the normal population for expressive language, visual motor integration, gross and fine motor function. Full-scale IQ score was assessed by the Wechsler Preschool and Primary Scale of Intelligence, and that was within an average range, but there were marked weaknesses in the visual, spatial, and visual motor integration skills. They had a speech pathologist who noted that despite having normal oral musculature and normal hearing, many of them had oral motor coordination and speech planning problems. So then they brought these kids back at 8 years. And so 8 years, what do you think about? They're in school, right? So now they're being challenged more. It's not just about so much play, but now they have academic standards, right? So the goal of this study was determine which of the two methods, whether they use the total circulatory arrest or the low flow bypass, which resulted in better neurodevelopmental outcomes at school age. So both treatment groups, there was no significant difference for most outcomes. But the total circulatory arrest group did worse on tests of motor function, things like manual dexterity, apraxia of speech, visual motor, and phonological awareness, which is important for reading. All those things you need for school, right? So then the low flow cardiopulmonary bypass group showed more impairments in attention and in behavior. So in the end, they said that the mean scores of most of the outcomes were within normal limits, but when you looked at the whole group, so both groups with both methods of surgery, they were well below expected levels in several domains, and you can see them listed there. But all things that are super important for our kids when they go to school. Then a couple years later, they took a kind of a deeper dive and they looked more at the results here. So psychosocial adjustment is an important dimension of long-term outcomes for children who undergo surgery in infancy. Although they have good psychosocial outcomes, the adult survivors of CHD have increased psychiatric morbidity, which includes major depressive disorder, panic disorders, obsessive compulsive symptoms, interpersonal difficulties, depression, paranoid ideation, and psychosis. So when they looked at these kids at 1, 4, and 8, the developmental and neurological outcomes were generally better for the low flow bypass group. That's okay. But then they wanted to look at the frequency of the behavioral disorders. So this study in 2009, they had ratings from the parents and then the teachers. And so when they looked at the whole cohort, so both operative methods, the frequency of behavior problems was identified by parents and teachers. It was elevated compared to normals. Approximately 1 in 5 had scores of total problem behavior in the range of clinical concern, both by the parents and the teachers. One thing that was an interesting side note of this study was the children that tended to have more social and attention problems were the kids that had postoperative seizures in infancy. So they concluded with this study, really looking at behavior and attention, that primary providers and specialists, who you all are, who we all are, we're specialists in this children's hospital that does all these great, magnificent medical things. They really have said that people who are specializing in children with congenital heart disease should all be alert for looking for these signs that there's these difficulties developing so that we can get appropriate and timely interventions to address these needs. All right, and then lastly, they looked at these kids, now they're facing adolescence, so things change, right? So some of the most compelling findings of this study was the impact of cardiac surgery in infancy and how it has effects on their neurocognitive and social impairments of their daily lives as teenagers. So this graph here shows you the kids with TGA versus the controls or the normative. So almost 40% needed tutoring in adolescence. 17% were held back at least 1 year in school. Almost 30%, almost a third, needed psychotherapy or counseling. So the need for additional services and therapies in large part is a large part of what their neurodevelopmental status is when they're adolescents. And then you're thinking about their transitioning into that early transition into adulthood, right? So what this study was also saying was that a lot of the focus for pediatric cardiac care has been on what we can do to lessen the burden of brain injuries. But what they really said was that what we really need to focus our attention on is to provide cognitive rehab to these kids. And I wanted to quote this because this was their last finding that they suggested. There's a clarion call for ongoing surveillance for neurological impairment in the congenital heart population. For school-age children and adolescents, measuring IQ alone is not sufficient. And they went on to say that screening should pay attention to their working memory, executive function, and social cognition. So it was that's why you can see why it was such a landmark study, just because of all of the, all of the good things that they were able to find and identify so that we can now shift gears and do the right thing for these kids. So I could go on and on about the countless research that there has been done about CHD in just the brain. And they look at it prenatally, after birth, preoperatively, postoperatively, and then as they age. But all these multitudes of study will show you that patients with CHD have delayed brain development. They've done it through fetal MRI. They have decreased sulci development in their brain. 23% of fetuses with CHD have ventriculomegaly and increased extra-axial space. And it's been noted that children who are full term with CHD have the maturation of a brain of that of a 35-weeker. So they're term, but because of their heart defect, their brain is making them preterm or immature, right? And then they have brain injury. That was the last part there. So this slide, I'm not going to go through all of this, but at the top, what I wanted you to look at is, so why did these kids have a brain injury? Like, what is it? So they have found all these different studies that are going to show you all the different things that can lead to these brain injuries and these central nervous system abnormalities. So I just wanted to highlight a couple, but prenatally, there's studies about the mothers have abnormal placentas, and that could be a cause. Preoperatively, it's they have decreased oxygen delivery, Intraoperatively, it's just being exposed to anesthesia as an infant or having circulatory arrest. Postoperatively, it can look like seizures. It can be caused from medication exposures, ICU exposures, and then in childhood, think about these kids who have repeated surgeries. Also, a thing that can cause these signs of abnormalities within the central nervous system is maternal depression and parental stress. And think about how many families we have that walk through our doors that have those things. So then on the bottom, what the central nervous abnormalities are going to lead to these potential neurological and or developmental findings below. So what some of those things that I wanted to highlight was prenatally or at birth, they have white matter injury already in their brain, they have microcephaly. Postoperatively in the ICU, they have seizures or stroke, like I said. They have abnormal mental status, or they have poor oral motor coordination. Then in childhood, you'll see things like delayed motor milestones and impaired executive functioning. A little bit more research continued. So there's another study that looked at children recovering in the ICU, and they found that each day that a child is recovering post-op in the cardiac intensive care unit led to a reduction of 1.4 points in the full scale IQ and 1.6 in math. That's per day. The other thing that has a profound effect is their length of stay is an independent risk factor for a worse outcome. So that's even adjusting for known variables of being in the CICU post-op and other variables that are already predictive of a poor developmental outcome. Like the most common one that comes to mind is just a lower SES of some of our families, or they speak a different language, so maybe Spanish speaking. So final research takeaways is that congenital heart disease is also a chronological neurological condition, and early intervention is key to really support brain maturation and prevent the neurodevelopment impairments that they are suffering from long term. Some of the long-term neurodevelopmental impairments, the estimates range from 25 to 70%. That's a lot. Lifetime prevalence of depression and anxiety for adults with CHD is estimated at 40 to 50%. So I don't want to feel like I'm doom and gloom with all of this, but I want us to ask ourselves, as a healthcare provider in the intensive care unit, what can we do here to prevent some of these neurodevelopmental delays? I will tell you, the power does lay in your hands. You can do that. You do have the ability to make an impact on these little babies and these children. So what can we do to decrease their long-term impact of these delays, and what can we do to positively impact the emotional health of the family during this vulnerable time? And as you all know, how important the dyad between the parent and the family is, right? So we know that it's difficult when the child is still here in the hospital. Early infant parent contact and bonding is the cornerstone for an infant's health trajectory, and relationships are enhanced when parents are nurtured and guided to support infants during caregiving. So with that, we're going to transition a little bit.
Okay. I'm going to talk to you guys a little bit about the synaptive theory of development. So before we kind of get into actual interventions of what we can do as caregivers to kind of help with everything that Elizabeth kind of just laid out there in the research, I just wanted to put this theory of development that we as therapists this is kind of how we practice and how we think about our babies. So the first pillar of this theory is that infant behavior is specific and has meaning, and that infants strive for integration, and that the infant is always in a continuous interaction with their environment. So there used to be very little knowledge about how infants have the ability to communicate with their caregivers. We used to even think that babies couldn't feel pain. So now we are kind of moved to this theory of development, and we want to look at how they're communicating with us. So the 5 subsystems of this theory are autonomic, motor, state, attention and interaction, and then self-regulation. So in a therapy session, PTOT speech, these are all the things that we're assessing as we're working with the baby. We let the baby kind of lead us through our sessions, and we respond appropriately to their cues as they're communicating with us with their behaviors. So for example, like each subsystem builds upon each other, right? So autonomic, if the baby is not tolerating cares well and is having desaturations or bradycardias with cares, obviously they're not going to be in a good place to do any motor activities with therapy, or they're not going to be in a place where they're going to be able to interact with their caregiver in a good way or have good state regulation for feeding. So that's just wanted to kind of lay that framework. Does anyone have any questions about that, or have you guys seen that before? Yeah. Okay.
Do you have questions?
Oh,
So I'm Ashley again. So are all of you are you just kind of split up West Nursery or kind of all over? I'm usually typically in
Yeah,
NPC,
all
but
over.
sometimes I kind of come over and help out in the South and the West. So I don't know. I recognize some of you, but not all of them. So I just get a little bit of how long you guys have been in the NICU, each of you, real quick. Left to right.
Since mid-February.
Okay.
I'm on week 4.
Week 4. Okay. Okay.
Week 2 or week 3, but I was in NICU and conceived
Okay. And then I already know Andy.
We all know it.
In a great way.
You can
Yeah.
still tell us how long you've been here.
Yeah, sorry. I did stop you. I apologize.
4 years.
Okay. So I'm gonna need a volunteer that's not Andy. I made eye contact with you. It's not a super long mat, but just lay down and relax. You may want to take your badge off just because it slides up to her face, I feel like.
Is Darby gonna be the
Yeah.
baby?
Relax.
Is Darby the patient? Don't worry, I'm getting all this on video, Darby.
Oh, that's wonderful.
Awesome. Don't worry.
We'll send it to Levine for social media.
See, we get involved.
So,
Yeah.
and when I get started, I'm just grabbing a couple of things, and then I'll have the rest of you guys stand up and just watch.
I was always getting taken nurse
Okay.
school.
Were you? You were
And
present with
then,
us.
can you hand me my work phone that's underneath that one?
Yep.
Thanks. Okay, so when you think about being in the nurseries, I feel like some nurseries have the lights down more than others, or, in some areas of the nursery are more quiet than others too. I felt like when I was pregnant, I was like, I would want my baby in here. I want my baby in this one, because this one's like nice and quiet and secluded and all that kind of stuff. I'm gonna have you help out too. You handed me my phone. I forgot. Yeah, if y'all wanna go ahead and just stand up or you get a seat closer. Get
This also
comfortable.
goes for like CVICU, PICU type stuff.
Yes.
So like kind of all, we keep saying either cardiac or NICU, but it's kind of global ICUs in all of the locations.
Right, and if you have ever like shadowed or worked in a CV, ICU too. Okay, so it's kind of similar. They are in their own rooms, but a lot goes on in there too. Okay, so when you think about when you're going to come in and do your cares with your patient, what's it like? Okay, you're sleeping. You're like you're
Your
quiet.
baby, your baby who. Nice and full.
All right. Hey, Elizabeth, can you help me for a second? I gotta do these cares. Let me see. I gotta get her diaper changed. So, did you watch the show last week? It was so. Oh my God. And then the Real Housewives of Beverly Hills. Can you imagine? I cannot believe what Kathy Hilton is gonna go through and what's going on with Kyle. But yeah, it's wonderful. Hey, you got your Oh, yeah.
I can do the temperature.
Yeah, thanks. Okay, and then I'm gonna get her staff right. Hey, what do you need? Oh yeah. Yeah, can you just tell them that I'm gonna call them back later? Yeah, I got a lot going on today.
Oh,
Yeah.
that's not a good one. You gotta do that again.
All right. Yeah. All right, thanks.
It's
Yeah.
never-
All right, bye.
Well, you don't feel cold. We're gonna do it one more
Why is
time.
it on?
Third time's the charm, right?
All right. Yeah, here you, okay. Yeah, let's turn her back. I don't care back. Yeah. I didn't even ask, how are your kids at Easter? How's all that going?
Oh,
Did y'all
we had
go
so
Easter
much
egg hunting?
fun.
Yeah, let's put that there.
Poor Darby.
Darby didn't know what she was signed up for.
God, this is such a fussy baby. I used to be about that.
With the sounds of the ocean.
Yeah, I think I cleaned her up. Okay, yeah, there we go. So how did that feel?
Darby's crying.
She's
crying. Laughing.
Do you want me to go ahead and just open the door? Are you gonna leave
That was the best.
So I know some of that can be a little dramatic, but.
Can she have a blanket to clean this up?
Oh,
Oh,
love.
yeah, absolutely.
I knocked somebody's coffee over.
You're good,
Yeah,
yeah,
you just
take
put it
that.
on there.
So even I myself have been with a baby and talked about my weekend, talked about my kids, and talked about what was on TV. But, you want to go to the next thing?
Oh, yeah.
You can get up and go sit down. Or if you need a minute.
Like, I might just go.
Listen, Ashley did that to me when we were practicing, and I was traumatized. I was like, I never want you to touch me again.
I was
So,
admitted and intubated at preemie for a day.
yeah.
Right, so y'all can sit down and get comfortable, or you can stay where you're at, it's fine. But nobody's perfect, and we all, talk to teammates and, all that kind of stuff. But we are, a level 4. I wanted to say 1, but that's not right, because that's trauma. Level 4 NICU, and what is best practice? We want to do what's best for our babies. When you unwrap that baby, they're going to be like this. So what is the best thing you can do to help limit that overstimulation? And what can that overstimulation do that's not good for the baby. So after doing the preemie for a day, that was a very big eye-opening experience when we all had that happen to us. So it really did change my practice. So when I would come in after that, literally, as therapists, I feel like I always keep the lights off unless I'm really looking at something. I use the lamp in the MPCN or try to dim it. I try to keep the blanket over because I realized firsthand how overstimulating that is. And we are frontline workers, and your job, especially in the NICU, is to keep them alive, right? I mean, your job is one of the most important ones. I mean, you're with them for 12 hours, where us doctors, nurse practitioners are just kind of stopping by and doing stuff. But I feel like when you're in that environment for so long, we kind of lose sight. You kind of forget, God, it is kind of like bright in here. And it is kind of loud in here. So try to keep it down, because then, you don't want to fall asleep at work either if the lights are off and you have to be quiet all the time. So trying to find where's a space away from the babies where I can talk to my coworkers and have a light on and chart and things like that. But that's just the most important part, is what can we do best for them. And I mean, even I have had to learn too. Did you want to add anything else to that? Is this me?
Yep.
And yeah, how does it affect them? So that it can make them a little bit behind in their milestones, where they're already like a 23-weeker is more than likely not going to be meeting those milestones when at typically 40 weeks, 44 weeks after, but us to do our best to make them not even further behind. I just got my neonatal touch and massage, and even like 35 to 36 weekers that we think of, oh, they're just the 35 weekers, they're fine, they're big kid, why are they in here? But they have an 80 to almost 90% chance of having sensory deficits older when they're school age. And we are keeping them alive, but those sensory issues that can start now, being caused now, affects that kid and that parent's everyday life. With either feeding or not wanting to wear socks, or affecting their school and even like social stuff. So what can we do here to help them with that? And it starts with just your cares. So even just changing little things like that can make a huge difference in helping them meet milestones later on. And I mean, I kind of said all this stuff. And then we're going to do some activities too about positioning and cares and all that kind of stuff. And these are just some of the stuff. I'm not going to read them all out loud, but I know we had the ears in the nursery for a little bit. And but you do get to see what a noise really makes and how it can affect. We don't think it's that loud, but it is to a baby. And another thing that I had to learn not to do is when I take a temperature, not to lay it on top. Sometimes I lay diapers there, but they're not noisy. And positioning.
And then not opening stuff at the bedside too, like if you're near an isolette or near a bassinet, like opening up different materials that you might have, that plastic, just that sound can be really distracting, overstimulating to the baby as well.
And with the smell is not leaving the wipes open.
And the ear she's talking about is like the little ear that you see in some of the nurseries that have like a yellow, green, and red thing that monitors the decibels for anybody that may not know what those are.
I do feel like we're doing at least when I've been in there and even trying to incorporate more in the NPCN is the sink cloths is being used a lot, which is so beneficial. I'm like, this man?
Yep.
I don't know what I was supposed to say to them.
Just kind of everything interacts together.
How it overall affects everything. So, which we're going to go into more detail about with touch, smell, taste, sound, and light. How that, when that bright light turned on, and when you open that isolette, or when you turn that cover on and open the isolette, some of those babies already have a reaction. So, trying not to rush to do their cares. And that's one reason why when we're in there, we kind of like to do cares sometimes. I know sometimes in the mornings maybe you want to get in there and do a full assessment, which we completely understand, but I like to do cares too, so I get to see how they're reacting. Are they overstimulated by certain things? Is there something I can do a little bit easier to calm them and help them tolerate the session? Sometimes all we do is cares at the very beginning when we first see them, especially like a 32-weeker. Or we know they can't tolerate much if you guys are saying, hey, they've had a rough night, or they had this procedure and they're just not there in pain. Sometimes just doing cares and some resting hands touch is all we're doing, and which kind of helps with their healing environment. And why is it important, especially with care? State reg is important for functional activities, bonding with parents, and we don't want them to shut down during care. So this baby looks pretty chill. It looks like she's probably making pretty good eye contact with whoever she's with. She's not fisted, she's not splayed, she's not bracing. She doesn't have the yeah. Botox is working. So that's your ultimate goal, is to have, that's what as therapists, our goal is, one of our main goals is state regulation. What can they tolerate? And then as they move from NICU to NPCN or NICU to the CV, still to be able to tolerate those things. And then, I don't know how y'all do handoff with CV, but maybe because those nurses don't know them sometimes as well as you guys have. Because sometimes even right after surgery, they're there for hopefully not too long before they go update, but you guys telling them, hey, they like this, or mom might like this. And, hey, let me bring down some scent cloths, because they don't have any of that down there, which we're gonna try and work on. So what can you hand off in communication to help with that state reg stuff before and after surgery? And to help parents out with the bonding stuff, because we see that as an issue after surgery. Parents are just terrified. So if they can get as much of that too before in NICU before they come down, I think would be really great.
And the goal after we do cares is to get babies into this nice, quiet, alert state, right? Like, we all have kids that scream through cares and then they're too worn out to feed or even interact with the family, and they're just like wiped because they were just crying for 5 minutes, right? So some of the techniques we're talking about is to help them with their state regulation so they can do better after as well.
Okay, so now we're going to kind of transition a little bit and build a little bit on some of those sensory pieces that we just talked about. I used to work in an outpatient therapy clinic that was really focused on sensory integration. So I have a lot of sensory background in how each of the senses are broken down and how they affect our kids later in life. So once I transitioned here and started working here, I definitely saw how some of these overstimulation things can really impact them. And seeing them outpatient, I could be like, oh, that was probably a NICU baby, or that kid's probably had surgery, or things like that, because you can kind of see how it affects them later on. So I added this cute little comment about being too loud because he looks real stressed out. So obviously we know the basic 5 senses, but in the sensory integration world, there's 2 other ones called vestibular and proprioception. So this kind of deals with movement, our body in space, and some of those more internal senses that we have. So that's kind of what we're going to dive deep into today. So I kind of just broke down everything. I'm not going to go through and read every single thing in here because you can kind of look through them. Tactile is obviously our touch system, so looking at touch, massage, positioning, bonding, 2-person caregiving, skin to skin, things like that that are helping their touch system develop. Smell and taste, so we're looking at sweeties, milk drops, scent cloths, things like that to build that sensory system in a positive way. Auditory, appropriate sounds, maybe no ocean sounds right in your ear. Using softer voices, things like that, so we can again build that sensory system in a good positive way and not overwhelm them with clinking and clacking and all the negative type of sounds. Visual, we've kind of gone through this, it's just kind of reiterating the dimmer lighting, focusing on their eye contact and tracking, and just giving that appropriate visual stimulation. Proprioceptive, this kind of comes with containment and providing some input into the joints so that they know where their body is in space. So if you notice a lot, babies in a swaddle will push against it. That's really good for providing that proprioceptive input, so that they can grow stronger, learn how to move their arms and legs in an appropriate way, develop that coordination that they need. They got a lot of that in utero, pushing and turning and moving and stuff, so that's kind of why we do the swaddles and why that's important. You'll notice a lot when you unswaddle them, they're like, you know, things like this. So that's why containment and that resting hands touch that we keep talking about is so important for kind of providing that input. In sensory integration world, the more proprioceptive input that you give an infant or a child of any kind, whether they're this age or 16, is a very positive sensory system. So anytime that you have to do anything negative, adding in some of that extra positive input is really beneficial in building that system and helping their brain learn that even though this is negative, we can integrate that together so that our body doesn't think that everything's going to be negative. So, can we play a little game? And you guys just tell me a little bit of what infant stress signs you've seen or noticed or learned about. Yep. Fingers flag.
Yep.
Racing. Anybody else?
Being super restless, I guess.
Yeah, for sure. Hiccups. You use that a lot. Okay, good. I thought this was a really cute picture too. Hiccups, sneezing, yawning, arching, splayed fingers, raised or furrowed eyebrows, gagging, facial grimaces, gaze avoidance, non-nutritive sucking, vital sign changes, increased work of breathing. All of those things are signs and symptoms that the infant's going to show us, and that's when we need to, 1, recognize those, 2, know how to interpret those, figure out what might be stressing them out, and what can we do to kind of ameliorate that and make it a little bit better or offset it a little bit. Oh, I spoke too soon. This is what I just said. So reading their cues and kind of responding to those. Obviously, if your infant's looking a little bit like this, you're going to want to kind of slow everything down maybe. Do your diaper change a little bit slower, transition, move slower, maybe give some resting hand touch or containment to kind of take a rest break before you keep going, because the more that you keep going and rolling and doing those overstimulation things, it's going to make it worse. And so just kind of looking, like these 2 babies are kind of making eye contact, they look like they're ready for more, they're doing okay. So just kind of learning and reading their cues in order to give them what they need. Yeah. Okay. little bit repeated. Helping the senses, so tactile, we kind of talked about this, holding skin to skin, resting hand touch, holding their little finger, doing the finger grasp. A lot of things that we do are infant massage, and we'll kind of break that down in a second. Containment, I've kind of talked a lot about. Two-person caregiving when appropriate. So we're also going to dive into that, but just having two sets of hands to do things, especially for a more medically complex baby or somebody who might be a little more stressed out or things like that, how we can use two people to help offset some of those negative interactions. And then reading and responding to cues. So, kind of diving deeper into massage and positive touch. So that's one of the main things we do. A lot of people think that when they get OT or PT, they're just doing exercises, and then they get speech, they're just feeding. There's a lot more things that we do as therapists, including massage, developmental positioning, working on state regulation, kind of like Ashley said. We may just come in and do cares. We may just do calming. We may just give them positive touch for 5 or 10 minutes and then leave. We can modify everything that we do based on their cues. So massage and positive touch are really good to build those sensory systems. Let them know that not all touch is bad. Whether they're in the NICU, the CVICU, the PICU, lots of tubes, tape, all the things that are not so fun. So we don't want them to think that every time somebody approaches them, touches them, looks at them, that it's going to hurt. So part of our role is just really developing that positive touch piece and teaching family really early about massage and how to interact positively with them, so that we can kind of, again, offset some of those negative pieces. Firm pressure versus light pressure. So kind of going along with the proprioceptive input and the touch. Firm pressure and very purposeful pressure or touch is more beneficial. If I just come up to you and lightly brush you, like that is a little bit more skin crawly, especially for our babies. So kind of thinking about the way you touch them, the way you approach them. Static versus dynamic touch. So sometimes I'll do massage and I'll have a baby when I'm trying to do a little bit of movement. They can't tolerate that. So then I'll just stop and do it really static and just really firm and not actually move, and they tolerate it a lot better. So we can kind of slowly progress them to where we want them to be by breaking everything down. Reading cues is important, and then modifications. So just kind of seeing what they need.
I'm going to talk to you a little bit about positioning, which is also still under the same realm of tactile. But our goals of therapeutic positioning is to provide opportunities for the baby to experience positions as are medically safe with their lines, tubes, and all those things as the infant would at home. And positioning really does matter because we're trying to prevent secondary complications that can have lifelong impacts on these kids as they age. Things like having asymmetrical range of motion, asymmetrical strength, which results in asymmetrical movement patterns and milestones, and cranial shape deformities. So when we think about positioning from a therapist perspective, there's really, if we had to sum it up, it would be supportive tuck posture. And what do we mean by that? So supportive tuck posture isn't out here, startled and out here. Supportive tuck is where we're flexed, we're tucked in towards the torso and in midline, not out to the sides, but in here. So some of the things that we want to avoid is retracted shoulders, and so that's when our babies are out here and when they develop shoulder tightness, things that can have an impact on their development is it can be difficult for them to then bring their hands together and hold a toy or hold their bottle. Even before that, if you think about tummy time, if their shoulders are tight and we're putting them on their tummy, they have no ability to push up on their arms to then lift their head up. So that's why keeping them tucked in forward is helpful for that. And not to mention that hands to face and hands to midline is soothing to help with that state regulation like the girls have been talking about.
And I feel like even like in my ultrasound pictures, you know, the hands were always around the face. Mm-hmm. Even at the 20-week ultrasound, this is where they always were supposed to be.
Mm-hmm. And another big one is avoiding the frog legging of the hips. So frog legging is where their knees are splayed out to the side. So we want to try to help keep their knees towards midline and give them a little bit of a foot support there. Things that can happen for kids if they're frog legged and they kind of stretch out their hips. When babies are young, your hip joint is a ball and socket joint, and it's very shallow, and then over time with more weight bearing, it develops deeper and deeper. But while they're shallow, that femur can kind of slide along in there, which can be hip dysplasia, which is another surgery. But also the other developmental implications can affect rolling over and being able to crawl. Another big one, an importance of positioning, is to really optimize cranial shaping and avoid a head shape abnormality. There's a lot of people out there, maybe pediatricians, that might say that cranial shape deformities are just cosmetic, but there really isn't the case. There's so much research out there that shows all the different implications, whether it's hand-eye coordination or vision problems, TMJ, headaches. So there's a range of different things that can have, if you think about it, a lifelong impact of that.
And I feel like even us just changing how we did the head of bed rotations has made a huge difference in that. I mean, it's just really like these little things make, it was like, double-digit percentages of babies that didn't have head shaping issues at discharge.
Right.
Do you guys know all the head of bed rotation stuff for some of you newer ones?
And then the CV world, they were not really able to do head of bed rotations just because of the vent and kind of the setup of those rooms. So it's really important to think about alternating which maybe side that they're laying on to offload the opposite side of the skull, or if they're on their back to actually rotate their head and just adjust the tubing of the vent just a little bit to allow them to go this way so that they're not always to the left. So I thought we could kind of have a discussion on these pages, but we're gonna go over a few positions. So what do you notice with this baby on the left versus the right? What are the differences in these positionings? What's something that you see that comes to mind on the left first? The biggest for me is the frog legging of the legs. You see how far apart the baby's legs are? Their feet are kind of just dangling off the edge of that little roll there.
Arms in the.
Mm-hmm. Yep. Her head's turned to the side, which could be okay if she was turned the other way last time, so that's not necessarily a bad thing. But the baby on the right, what do you notice?
So you can start the midline.
Yep, that's that supportive tuck. That's a really classic supportive tuck right there. Head's in the middle. Hands are, look at how her hands are tucked right here, just like in that in utero position. Her feet have a little bit of a prop. Her knees are together. Yeah.
Big ones for these that I've noticed, at least with mine, is like, look, babies with low tone or Down syndrome or some of those, they tend to, I don't want to say the word flop, but be in these positions a lot more often, so they take a little extra of our support to make sure that they are positioned in that. Or post-cardiac surgery, when they want to keep their arms here and they've had their arms here and everything is just here. So kind of working on bringing everything back.
And so the only other thing I wanted to add about these babies, we picked these pictures without the swaddles just so you could really see their alignment. But a swaddle would be another really great tactile input and an external support aid, right, to help with that tuck position. So not all of you have a drink here, but what I want you to do here is I want you all to look up at the sky and I want you to swallow. And it's so hard to swallow when you're extended, right? So this baby on the left, he's turned, but in my opinion, he kind of looks extended here. And I don't know how long he's gonna have that tube in there, but if he's always like this girl right here is gonna have a hard time, and the baby to eat, right, and the parents. So what I notice on the left is that. What do you also notice on the baby on the left? That baby's arm looks like he's probably back here, right? So he's gonna get that tightness in those shoulders. And he's got all those stress signs in his forehead, right? Saying, I'm not sure about this. And then if you look over at little cutie pie on the right, it looks like a bendy bumper, but if you don't have that, you could use a blanket roll or mold your Z-Flow. But that baby is nice and tucked. Look how his shoulders are rounded and they're forward. And the head is all the way in line with the body moving down. He's got his hands right up here where he's like, I'm gonna be okay, I'm okay. And even his pelvis isn't out here. His pelvis is tucked, which is really important for development to have that tuck there. And his legs aren't out to the side too much. That looks like it fits him appropriately, where his knees are probably still in general alignment, right? And then prone positioning. So, what do you notice about the picture on the left?
Arms are way out.
Mm-hmm. That
And
one arm is
legs
really.
are frogged out too.
Mhm. Yep. Yep. But they tried to support, maybe he squirmed out. But, so then, that does happen though, right? We get them all aligned and they're like, well shoot, now they just moved, and then you just spent 20 minutes setting them all up. So maybe you need to add, fold a blanket and make it a little bit thicker if you think that they need a little bit more of that containment, a little bit of that tactile proprioceptive input. That baby on the right, it looks like they're using a little prone pillow. Do you guys still use prone pillows? Do you have them in your? You don't have
They
them.
discontinued the product, and I don't think we bought any since the original ones.
Right.
But I just use the bottom of a demo row that's, for their hips.
Yep.
Or
Yep.
a hat or
Yep.
a pillow.
And so I think the important thing with prone is it's not gonna work the same. It's not like a straight standard recipe of like you use 3 rolls and this and you're good to go. Like there's so many variables, right? With how big your baby is, their age, how strong they are, what lines and tubes they have. So, it's critical thinking and creativity combined to make these kids look what we say pretty, where that baby on the right, his shoulders and his elbows are under his shoulders, so he's getting some of that weight bearing. His hand is near his face, which is what we want for development. And then you can kind of see his hips are tucked so that his knees are up under his pelvis. And I really love those hands too, so I think Rachel found this picture too, but that's really, really good positive touch. Sometimes before you do cares, kind of take a time out, like how surgeons do before surgery. Just take a time out and just take a self-awareness of like, where am I? And look at your baby, look at the monitor, and just kind of bring yourself back. You just like did whatever, you coded that baby over there, you admitted this one or whatever, and just kind of bringing your senses to like, how am I gonna touch this baby with intention? And really just kind of melting your hands to that head and to that pelvis, and just start there and just wait. And then do what you need to do. You have an extra 15 seconds to really just put a good imprint on their brain. So prone positioning is so important in development. It's one of the most important things that you can do for your baby. A lot of benefits come with prone positioning. When you think about the medical side, prone positioning improves with ventilation and decreased work of breathing. Sometimes as a therapist, when my babies are prone, not necessarily always in the NICU. Well, yeah, sometimes in the NICU, but in the CVICU, I feel like if that baby's prone, that baby's probably sick, just because of the respiratory ventilation benefit there. But from a developmental standpoint, why we like tummy time so much is it helps with bone mineralization and muscle strengthening. It promotes fine and gross motor skills progression. And especially if the baby has a preference to turn their head to one side or the other, and if we're seeing some craniofacial asymmetries and some flattening, prone positioning is a great way to really offload the side of the skull that is getting too much pressure on one side to try to round that out.
It's tolerance to another position too.
Wait for it. Go.
Safe sleep. So I know you guys are in NICU, so you don't, that's not usually your primary focus, but you do have babies that you send home, right? You have your sleeping in rooms and babies that go home. So here we just wanted to just kind of highlight how important safe sleep is about getting your babies ready for discharge. And we do have a role to model what safe sleep should look like to these parents. And not only that, but just to really set up that baby for success, because we know that interactions are important, feeding is important, all the love and nurturing from the family, but it's also important for good sleep. And so we want to set that baby up for success, to be used to the environment that they're going to be sleeping in, so that the baby can sleep and so that the parents can sleep.
I swear I heard something.
It does.
When it comes to, I wanted to say one more thing on that. When it comes to more of the cardiac babies before they go home, sometimes we know when they have certain medical things going on, like it's a certain reflux or if there's a certain cardiac defect, there is a discussion that happens with, it's not just up to therapy, there is a discussion with GI or cardiology of, they actually will have an order to have had a bed elevation when they do go home. So we do know that sometimes they can't be for certain reasons.
And I think just educating on the more newer school version of Safe Sleep, whereas when I grew up, it was like bumpers and blankets and stuffed animals and all the cute things, and that's not really what's recommended now by all the professionals.
And I think, we take care of the sickest of the sick, right? Which is really great that these babies, we're getting them home to their families. And when they're very sick and they need this medical care, they might need a lot of supports. They might need a wedge and a Z-flow and rolls and all the things. So we're not saying to just rip everything out. If you're going home, and it's a gradual progression. If you have these big rolls, wean them down to smaller. Maybe take this one out. They're doing okay with that one, then maybe you take these two out. So just kind of gradually transition them, not quitting everything cold turkey. This is a great picture. So why is positioning so important? So you might be asking yourself, well, I'm taking care of these preemies, or I have like a 9-day-old, is really the way I position really gonna matter? And yes, it does. It does matter. Because when they are positioned properly, they're given the proper opportunities to develop and get stronger, which is going to lead them up, set them up for success with their milestones. So by giving a baby good positioning on their back and on their tummies, they're gonna be tucking their chin off the surface and getting that good kicking and bringing their hands up and then starting to bat their toys. When they're older, they're gonna do really great prone push-ups and weight shift and reach for their toy and then start to crawl, and you kind of get my drift. But it does matter because you're setting their bodies up for success with their strength and their alignment and their motor skills. Okay. Now comes the fun part. Dana and I, we're gonna do a couple things with you. First, we're gonna do some positioning, and we brought a plethora of baby dolls and a plethora of things that you can do to position them. And we're just gonna kind of go over different positions and giving babies optimal alignment.
We want to do partners?
Doesn't say 2, 2, and 2.
Do you guys wanna be with a partner? Or do you wanna do your own? You got enough?
Probably have enough for most people to do their own.
Yeah.
If you want to be by yourself.
Let's do partners.
Partners?
Yeah, because it's a two.
You want to pass the
Two,
phone?
Yeah.
This is an ideal situation of what two-person caregiving might look like.
Hey, how's it going?
Good.
Is it okay if I come on in?
Yeah, I'm just about to do all her things. She pulled out her NG tube and she needs a new diaper.
Okay, is it okay if I just kind of help for calming and
Sure.
state regulation?
Sure.
Okay, great. Okay.
Oh, she took the finger there.
Here, I'll lift her up very slowly. You can do that. Awesome. While you do the diaper change, I'm just gonna do a half swaddle, if that's okay.
Okay. You wanna keep her up? You wanna keep this part up here?
Yeah, that'd be great.
And we'll bring her back this way.
Okay, 1, 2, 3. So I've got her hands up at midline, I'm providing containment, cranial containment to her head, while Elizabeth is focusing on just doing the diaper.
Like hip flexion,
So really just lifting up their bottom and not pulling up on their hips here. So just kind of scooping their bottom right there and getting that diaper up under there.
She's doing good, she's starting to wake up just a little bit. She's getting a little fussy here. We'll go a little bit slower.
So break it down that sensory, instead of 100% negative the whole time, jerking the feet, open swaddle, frantic. They're kind of, 50-50, so that baby's getting less negative and a little bit more positive to kind of integrate those systems in the brain.
Other side. And I need to switch out your sap probe.
Okay?
I think we used one already.
You used it?
oh yeah.
Okay.
Darby had the blood pressure come
Yeah,
off.
it was on her face.
This right here.
You're good.
All right. And I do need to drop a new NG tube because she loves those hands up there.
Okay, while you do that, I'm just gonna, do a little bit of sucrose with her passy before we do that.
It's
Okay.
right here at the bottom, underneath the blanket.
Oh, thanks. Alright. She's starting this up. So this is gonna create, an opioid release for her, a couple minutes, if you do it for 2 minutes before you do, any sort of noxious procedure or something that's gonna be uncomfortable for the baby. So if you have an extra 1 to 2 minutes to just do, some, sucrose with the baby, that'd be good, okay?
Get in there? Okay.
Yeah.
You're ready.
Now provide containment. Let's actually fix her whole swaddle before we do that. Provide all the containment. Perfect.
Okay. I'm gonna put this in.
Wow.
Don't forget to see that.
Yeah,
right.
yeah.
Oh, okay, look, she took her passy right back. She's pretty calm. Good job.
In a good spot.
Awesome. Is there anything else you need to do?
That's everything I need to do.
Is it okay if I do some milk drops?
Sure. Can I get you anything to do that? You have everything you need?
Yeah, let's just turn her gently to the side. Perfect. And then as long as I have a syringe with some milk in it, perfect.
There you go.
Get some mom's breast milk. Awesome. Do, do, do. All right, and I do that for my session until she falls asleep.
So it's really kind of,
Good night.
so it's really kind of buddying
Just
up
for
and
effects.
and really kind of having a buddy to be with you, just to give them more of that positive touch, to really focus on organization and calming, and just taking breaks as needed, and not just like the huddle up, hurry up offense, and just to get it over with to move on.
And we know that y'all aren't always gonna have time
Right.
to have 2 people at the bedside at all times, but.
Sometimes it's just not possible.
Or have time to take 20 minutes on cares.
Right, but if it is a slower day and there is someone available, or there's a therapist walking by and you have a tough kid or whatever it may be, that's what we're here for, and that's what the family could be a part of too. Like
Right.
us teaching the mom or the dad that's at the bedside, these methods of containment and going really slow and having them be a part of things. That's a really great way to get them involved when maybe the baby isn't doing a whole lot else. So we're gonna do one more activity. Do we want them to act it out too?
Sure.
Okay, so we're gonna do one more activity with your babies that you already have, so we know what that means, that's good. Important to have one person that's focused on the baby's state and another person that's focused on actually doing the cares, the procedure, whatever it is. We all know that crying babies can lead to desaturations, they can be more difficult to soothe, and then that's really stressful on parents. So make sure if you don't have a second person, or a nurse or a therapist or an RT that's available, if a parent's sitting there and you think you can kind of coach them on how to be helpful, make sure you include them in that. And then we really want to change the mindset from they're too sick for therapy to let us help you guys meet the needs of the patient. We're here to help. We're going to modify our sessions to help that patient.
There are times when it is inappropriate,
Yes.
and it is
yes.
completely
Yes.
okay to say that, but like, I don't wanna, don't say, well, I guess it's okay, and have a code card next to them. I'd be okay if I don't see them.
Right, exactly. All right, and this going back to the sucrose or the sweeties. So we've had some studies that shown non-nutritive sucking and sucrose for neurobehavioral support during cares or during a painful or uncomfortable procedure. So changing an NG tube, a stick, anything that you know is gonna cause pain, you can, if you have that extra 2 minutes to get them sucking on their passy, dropping a little bit in the side of their mouth, that's gonna actually allow for an opioid release in their brain that's associated with the sweet taste, and they will actually not feel the pain quite as badly. So hopefully they'll help maintain their state regulation by doing that. Another thing that we know kind of helps with pain impulses is vibration. So think about when you kind of pat a baby's bottom rhythmically, they stop crying sometimes, right? So the theory is that vibration modulates the peripheral and spinal afferent impulses, which can dull the pain impulses from reaching the brain. So sweeties is a good method, patting is good, and then this little twisty snake is also good to put around during a painful procedure. And then just the importance of cluster cares. Y'all are so good about this in the NICU. Honestly, we need to work on this in CV a little bit more, but cluster cares, you guys are very good at kind of protecting the baby's rest. You know, we know as therapists, we don't come any other time except 20 to 30 minutes before their care time or at their care time. So keep doing that. It's really important for their rest and for their development that they get really good sleep. Again, this is more in the CVICU, but daylight versus shades down. We have had some infants kind of come out of the CVICU with ICU delirium just from either always having the shades drawn or being woken up at all hours of the day and turn that bright light on from dark to light. And we can think about that too, you know, with our cares in the NICU. If you go from a dark isolette with a big blanket over it to turning the lights on and an unswaddling, that's very startling as well. So thinking about that. And then just coming up with a developmentally appropriate schedule for each patient. Again, as we do have some lifers in the NICU that get older, celebrated a couple first birthdays. So, you know, we don't need to do the every 3 hours for them. We want to target them when they're during their play times and their alert times and that kind of thing. So just thinking about that as well.
I think too, just to mention like that communication, like we rely on you guys to tell us how they're doing and kind of what we mentioned earlier. So like if we, you know, we kind of make our schedules from day to day. Like we don't ever really have anything planned out other than the care time. So a lot of times I'll talk to the nurse. I'm like, hey, can I come at like 10 or 10:30 before they're 11? And they're like, oh, they just fell asleep and they had an eye exam. Like, could you maybe come in the afternoon care? So even just that communication, like, oh yeah, then I'll go pick somebody else up now and come back 2 years later. So even just that communication to make their cluster care even better is helpful for us because we don't know what all they're going through. So that's why we rely on you guys for some of that information.
I'll stand, I'll stand for a minute. We talked about the sink cloths and how important it is. I feel like it's obviously important for the baby. It helps with feeding. It helps with, but it helps with that bonding with the mom and to make the mom feel useful, especially when they're in the isolette. Sometimes, you know, you just see the mom sitting outside the space, maybe reading a book or looking at her phone. Putting milk drops on it can help. Just wearing it, it gives them a purpose. And for the dads, I think we always say it to the mom, but then I feel like we always leave the dads out. I have done it too, where I go into the bed space, I'm automatically making eye contact with mom and talking to mom, where I feel like, oh, I need to make sure I'm including dad and all this stuff too. Because I had someone I personally know that was in the East, and I did that too with her and talked to her about, oh, you need to hold the baby, you need to do this, you need to do, it's really good to do skin to skin, and I made that conscious effort, looked at dad. Oh, I'll say, look, you need to do it too, you need to bond, because there is that kind of attachment sometimes, or they just, and the dad sometimes will automatically look at the mom for that. So, scent cloths, kangarooing with both parents. I know we emphasize it at the kangaroo-a-thon every year, but it's so important for them, for their development, for their, it helps with vital signs, it helps with feeding and the smell and the bonding. It helps with moms with the postpartum stuff too. And I know you've probably seen videos or watched, but even that two-person caregiving to get the baby to mom and to dad. Getting them comfortable. I know you put the screens up too to give them that time, and that is another time just say, hey mom, we're going to do skin to skin. Oh, well, I'm just going to completely not go in at that time because that's 100 times more important than us at that care time. And we mentioned earlier about the wipes, alcohol swabs, all that stuff. Try to keep it away from the baby and take it out when you're done.
And when you sanitize your hands, let your hands dry.
Yep.
So that they're not inhaling the fumes of the sanitizer that's still wet on your hands.
Because you automatically go right here, right by their face when you're doing that with the hand sanitizer. And then we talked about the sounds. Try and keep it as low as possible. I know I had her call my phone while I'm talking on the phone at the bed space. We do have to answer our phones, but try and have your settings low and then talk in a soft voice. again, when you're in that environment all the time, you kind of forget it, but we just kind of have to make ourselves consciously aware to have soft voices when you're at the bed space. And then maybe chart and talk and all that stuff when you're away from it. Is there anything else on that one? Oh,
So
yeah.
please.
These are okay at times with older babies. I feel like in the NICU, term babies, okay, but it's really supposed to be feet away from them. So really not even in their bassinet, isolate, radiant warmer. It shouldn't be, and when you see it there, it's usually up here. And you want to keep it feet away, so maybe have it somewhere closer to where you're sitting. And think about when you're hearing this for hours at a time. I know on the floors, in the ICU and even PICU, when I've had an infant recently, I had just seen where they had the computer set up and they had listened to nursery rhymes for 8 hours and it had stopped. 8 hours is a long time to listen to music. Even sounds. They don't have that in utero. They're not listening to that for 8 hours at a time. That is overstimulating. A lot. And if you're gonna have, I know there's in NICU, there's not a great place to put it, but have it on the lowest possible setting if you're gonna have it maybe a little bit closer to them because of space issues.
I was gonna say, I've seen people like hang it up by the monitor and have like when the feet are towards the monitor, so then it's like a nice distance away as well, but still in the bed space.
And you don't wanna be able to hear that noise from where you're standing. You only need to be able to hear that noise when you're standing here. That's my best way of knowing if it's too loud or not loud enough. You're only supposed to be able to hear it when you're right here.
I think what happens is our nurseries get really loud, so then we
Yep.
think we need to turn it up and put it right next to their ear so they can hear it, versus thinking the opposite way of like, why do I feel like that? How do I make it quieter?
And then the benefits, or examples, is like hearing helps us develop language skills later in life, decrease noise by preparing your nursing. I don't want to read all this. But honestly, I think sometimes more important is you softly talking to them. And then music therapy, well, that's going to go into the next slide. We'll handle that one. Did a great in-service one time about how the nursery rhymes are when you sing. It's all this. It's not highs and lows. When you think about Twinkle, Twinkle, Little Star, it's the same as almost like A, B, C, D, E, F, G. It's not highs and it's just a very monotone low thing. And that's when you're whispering and when you're softly talking to somebody, that's how you sound the same. So all that is so beneficial. And then sometimes I hate that when they get to be termed that we're still, I mean, I know we need to wear a mask, but like I wish they could see our mouths moving and stuff a little bit more. But that soft talking and soft singing to them, personally, face to face, and making that eye contact is, I think, more important than the sound machines. So trying to do that, I try to do that when I'm coming in for every cares. So TV versus music versus sound machine, kind of said all that. But the computers at their faces, and they're not hot TVs up there, but that's an issue we have on the floors, is having the TV on or playing a movie or playing music that way, and then the call bell is up there or somewhere, or right up here at the top of the crib. So we're trying to get away from that. And that's where we're seeing them hanging them up. They'll hang the call bell up by the monitor. I've seen a little bit. Just a little bit. Was there anything else on
That was just the,
a big thing they do that's on the floor sometimes is Moana. I see a Moana.
Moana.
screen time HD.
Oh yeah, screen time under age 2.
Yes. So any baby, you don't want screen time. I know that's hard when you have your own kids, especially as you have 2 to 3 to 4 kids. But it's just what's recommended. It's for vision and noise. It's not good for them.
But I mean, I think a lot of us worry like, oh, their mom's not here and I don't want them to be bored, but a baby, like neurologically, is not going to be bored. They are happy to just look in their surroundings and be calm and be able to look around and, that visual scanning and tracking. So they really don't need the screen.
I like that when they become term, the pictures that you sometimes see, and those little mats that have the pictures in a mirror, those are great. The one thing is, sometimes those fish bowls can be loud, and that's a bright light, right in there, and it's right in their face.
The aquarium.
Yes,
Yeah.
sorry, I call them fish, sorry. I don't know why I called it a fishbowl, that's the place in the old ICU.
Yeah.
We do like to work with child life a lot too, to get those items and make things more developmentally appropriate.
And I know I've seen on the floor sometimes, they'll hang stuff like that from the radiant warmers too.
And I've seen
That's
people in
nice.
8 do the little IV tubes, like from the crib to
And hang the
crib,
rattles.
and the crib in and hang rattles and things, so that they can reach and play and look at those things.
And like the rattle teeter toys, they'll hang from that, so it gives them something to look at. It's a little bit more developmentally appropriate.
And if they're like 1 or 1.5 and can reach and pull, you know, they're getting resistance and reaching and things.
I do like what, the mobiles are great once they're term, but the aquariums aren't my favorite. Just because they're loud and it's bright and there's nowhere else to put it except right by their face. It's a lot. I
Oh, that's me. My bad. I didn't close my door over. Okay. So continuing on, I know we're kind of harping a lot on sensory, but things we can do for visual. So again, those bright lights, a lot of times, especially as nurses, I know you guys have to turn on the lights light. You got to see and check and assess and do a bunch of things that we don't have to do. So just kind of utilizing those dimmers and things when you can. Like Ashley said earlier, a lot of times when we go in, the lights are always off, so you'll see us working in there, the lights are off or either dim, just to kind of, again, reduce all of that. That cycled lighting, so for babies and or olders, especially the chronic ones that are here for a while, sometimes we get our days and nights mixed up. So facilitating that cycled lighting where we keep a little bit of light or natural light or a small lamp or something, or the blanket off of their isolate a little bit so that they know it's daytime and more dark when it's nighttime so that they kind of stay on that rhythm. And then again, we've kind of talked about this, just when they're in a good state and you have time to sit with them for a few minutes, hold them, look at them, sit them up in the bed, work on visual skills, look at them, talk to them, move your face back and forth, give them that chance to enhance their visual skills in a good positive way. Then kind of breaking down a couple more sensory systems, kinesthetic. So this is kind of like what we think about with the baby moving their arms and legs. So being able to move themselves and learn about their body and experience those things. So yes, we want them to do half and half swaddles and containment and things, but when you slowly unwrap them in things and they're still in a nice, good state regulation and they are okay and they're not overstimulated and stressed, allowing them to explore their body and move their arms out a little bit, allow them to see kicking. We've talked a lot about cares and being involved in cares. A lot of times you'll notice when you go to do diaper changes and things and they're unswaddled, they do reciprocal kicking. That is a very developmentally appropriate thing. Not all babies do, but we want to see that. So just kind of allowing for some of those movements in a positive way versus unswaddling and then everything being like. And then the last one that we kind of will talk about is the vestibular system. So this is all about movement. So when you think about transitioning a baby from their bed to a parent, or changing their position with respiratory, or having to sit them up and change all of their linens, that is a lot of vestibular input. When we come in and we transition them from this position and take them all over into prone, more gently than that, thinking about all of that movement and how much that is. So kind of how we've talked a lot today about moving slowly, maybe from their back to their side over to prone a little bit more gently. So getting them used to that. If a baby normally is born and goes home, they're getting held, they're getting bounced, they're getting passed along, they get all of that. So their systems develop slightly better. Whereas when they're in the hospital, they spend a lot of time in a crib on their back, right? So they have less of that movement. So those systems are typically underdeveloped, and it's our responsibility to kind of help them develop that and give them that movement in a slow, gradual form so they learn to tolerate it and they don't go from this to going home and being passed around to all the grandparents and all the family members and like, holy wow, that's like 0 to 100. So, water bottle example. I was taught this in my old job, and then I used it with a patient on the 8th floor that actually Dana and I treated together. He was another infant that did not tolerate cares, did not tolerate transitions. And what I mean by that is even just laying on their back to sitting, laying on their back to being on their belly, or transitions all the way out of the crib. Mom used to talk to me like, I can't get him to calm, I can't do anything, he doesn't want to be held, he doesn't want to do this. So again, we spent a whole session and broke everything down, moved a lot slower, talked about all of the things that we've talked about today, and I used this water bottle example. She did what I told her and kind of practiced and then cried because she, for the first time, transitioned the baby from the bed to her lap. And she actually felt, she's like, I did what I'm supposed to. He enjoyed it. It wasn't stressful. So anyways, that was just a big thing. So I use this example a lot. And I tell a lot of people that shadow me, students, nursing. So we have fluid in our semicircular canals in our ears that tells us about the vestibular system, our movement in space. You think about going to get on a roller coaster right now, all of that movement and all of that stuff. So I usually will demonstrate this because I'm a visual learner. So if you think about the fluid in your ears as the fluid in this water bottle, if you think about a baby here, when they did 2-person caregiving and everything was moving slow, that water's just kind of gently moving, right? It's nothing too crazy. It's really good. They're tolerating it. We'll sit them up. We'll do a little bit. Maybe we'll pick them up and transition them to the family to hold, things like that. It's very gentle and it's not overstimulating and it's very positive to them. Whereas when Ashley and Darby hung out earlier, it was a little bit more like this. So it's a lot more aggressive. So kind of just breaking that down. So family a lot of time comes in and they don't understand as much. So they just like do all this and they get them here. And then they're like, oh, they're fussy. Let me pick them up. You know, so you think about all of that movement and how much that is a big change. So just kind of breaking everything down. So I like the water bottle example.
That's a good one for families too, if you're trying to explain this of like why the family shouldn't pick them up by their feet or move them too quickly. I feel like families really understand that example better than sometimes going into all the research and all the stuff that we're going through right now. So that's a quick and easy way to explain it to families as well.
Okay, and I think this is the last one and then we'll kind of start tying it up. We've kind of talked about this, so I'm not going to provide a whole lot. The proprioceptive, that's all that containment, that deep firm pressure, that positive touch, weight bearing when they're in prone, a little bit of resistance, like when you do that containment and they're working on kicking, they're kind of kicking against you, which gives them a little bit of resistance, which is good for strengthening and learning about their body, where their body is in space.
Because in utero, they're pushing into your belly. They get that bounce back, so it does help with like bones, muscles. So this is our way in the NICU to help provide that as much best we can.
Right. And you think about like, you know, if you're doing push-ups, you're learning a lot about where your body is, how far, how high, where it's at. I describe it too with a gas pedal. Like we know because of our sensory receptors how far or how less to push on the gas and how, you know if you push it way down, it's going to go real fast. So some of our babies just helping develop that sensory system that we have all kind of learned. So tying it all together, what we do matters. So everything that we do matters. We are all a team together. We all have our strengths. We all have weaknesses that we can all improve, including ourselves. I mean, we are teaching you this, but we've learned from each other even making this presentation. So just that communication, opening all up. Carryover is key. So again, teaching other nurses, teaching shadows that you have, teaching orientees that are coming in, teaching families so that they carry it over when they're at the bedside and at home. Small details are big and kind of change things long term. Yeah. Okay. We've kind of talked about this. I'm not going to go over this one. We just kind of talked about developmentally appropriate things. So the TVs, the sound machines, interacting with them personally, things like that.
All right, I know we're running short on time, so I'm going to go through this last part quickly. So positive pre-feeding experiences. We're going to just kind of switch gears to talk about feeding for this next little bit. Doing oral cares with mother's breast milk. Do you guys do that already? You do? Okay, great.
Skin to skin with both parents, scented cloths, encouraging hands to mouth. I know you guys can't always do this because they have NG tubes and cannulas and ET tubes and everything, but if they're being supervised by you and allowing them to have some time with their hands to their mouth is really important. Or if you have a really good family that you're like, please watch their hands and we want to allow them this time, that would be ideal. Milk drops, and of course including the families. A lot of these families don't get to just go home and breastfeed and bottle feed, and a lot of them are grieving the loss of that normal experience. So just making like all of these little things a big deal. Like, oh my gosh, we're doing milk drops today, isn't that exciting? We're gonna do skin to skin, that's huge. It's a huge step towards feeding, making every little thing a milestone for these families. Thank you. So how can we support breastfeeding? We all know research shows that mom's breast milk and breastfeeding is the most optimal nutrition for neurodevelopment. You guys do a great job of this, making sure mom has a pump, encouraging mom time and space to pump. You know, I think a lot of times in the NICU we don't have the privacy, but you know, drawing the curtain, if the doctor's coming around, make sure mom is okay with that, those kinds of things. Just thinking about them and being respectful of their time and their space and trying to protect that as much as possible. Doing skin to skin and holding during a tube feeding if they're not ready to feed quite yet, and then if it's cleared by the team, the first feeding experience is always best at the breast. The baby is able to control more, and it's usually just an overall more positive experience. We all know what cue-based feeding is here. The importance of first feeding, we want to make sure that when they are swaddled for their first feeding, we want them to be in midline and flexion with their hands up near their mouth. We want the environment to be dim lights, quiet environment, so it's not overstimulating, and all the baby has to do is focus on feeding. Sideline for all first feeding experiences. I do know that there are some babies that are coming back from CV back into the West after their cardiac surgery. There's some times where I'll recommend right sideline position rather than left. Usually most of us feed babies on our left side because we're right-handed. Sometimes I recommend to flip that. There's a lot of concern for vocal cord paralysis following some cardiac surgeries, especially involving the aortic arch. And in right sideline, it allows for adequate vocal cord closure, so it's a little bit safer for that baby. Nipple flow rate, we want it to be breastfeeding or the tan nipple for the first feeding, especially following a cardiac surgery. Watch closely for stress cues, and then obviously we just don't expect our babies to just take off with feeding, right? It's a developmental skill. It's a huge milestone to even just be able to try a bottle. So even if the kid just takes 1 ml, you want to celebrate that and make it a big deal to the parents. All right, if it's not their first time feeding, this is a slide more for CVICU, but if they come back to the NICU after a cardiac surgery, I want you guys to kind of treat it like it's their first time feeding, going back to the tan nipple, watching closely for stress cues. A lot can change with their anatomy after intubation, extubation, maybe a vocal cord injury. So I want you to treat it like your first feeding assessment and treat it like their first feeding again. And then the other 2 things are for CV, but if they have dysphagia or on thickened liquids, always want to get speech involved. Okay.
Wait for it.
There we go. Oral aversion. I know this is a hot topic where even just for all NICU kids, but especially with cardiac infants, it can happen due to just repeated negative oral experiences. So a lot of suctioning, prolonged intubation, having no G-tube for a long time, not having enough positive touch or positive stimulation around their mouth. So that's why it's so important to get their hands up near their mouth, even though we don't want them to grab and pull something out, just allowing even just a couple of minutes a day, that would be great. So negative experience can also just be from stressful PO feedings before they're physiologically stable. So we all know those kids that have apnea, Brady BSATs when they're feeding. Those, even if it happens once a day, those experiences over weeks can add up to an oral aversion. So If it's your first day with a baby and you're like, why are they having events with feeds? I want you to question that. I want you to look into that. It's not, yes, preemies are supposed to learn how to do it, but that's not a normal part of development. They're not supposed to experience those negative vital sign changes with feeding. And then cardiac infants in particular have poor GI tolerance due to poor perfusion in their gut and utero. So we often see those kids need to be on like Alimentum or Elecare, really broken down formula, and oral aversion can stem from just GI intolerance in general. My rule of thumb, this is what I always teach parents with PO feeding, 3 strikes you're out. So looking for 3 stress cues throughout the feeding, and if they show you guys stress cues 3 separate times throughout the feeding, even if they didn't fall asleep or even if they didn't have a DSAT or whatever it is that would signal you to stop the feeding, I want you guys to stop, because that's all of these stress cues are can lead to an oral aversion. So wet breath sounds are a sign of aspiration, arching, displaying their hands, tachypnea, drooling, pulling away, coughing, choking, squirming. Even just having like a really loose latch on the bottle, like you give the kid the passy and they're like going to town and you like can't pull it out and you're like, wow, you got a good latch. And then you put the bottle in and it's drooling and they have a very loose latch. That's the baby's way of telling you this is either too fast or I'm not ready for this. So that's kind of their way that they modify it. Know the flow, don't go with the flow. So feeding with a slow flow rate allows for more breathing breaks. And even though feeding with a faster flow rate is going to decrease the amount of feeding minutes, and maybe you're going to get the volume in quicker, it's going to increase the cardiorespiratory load on the infant, right? They're not going to have that nice suck, swallow, breathe, suck, swallow, breathe. They're going to be suck, swallow, and then catching up. You always see that breath stacking with that as well, or increased tachypnea. So we want to make it a very pleasant experience for them. We don't want to increase the cardiorespiratory load, and we want them not to be stressed with feeding, so they want to continue to feed. And then, decreasing the flow rate or slowing the flow rate improves their ability to regulate and learn that suck, swallow, breathe coordination on their own time. This is my favorite slide. It's from one of the, a recent research article, and it says, give a damn about flow rate. So current research suggests that physiological stress, behavioral distress, and feeding related to, fatigue and related to feeding infants with medical complexity worsens with faster flow rates. So we've been seeing this research for quite some time, and that's why we have those infant nipples that are so slow, the tan and the purple. Those are really great places to start. So I'm glad we have them available in our units.
Only a few more slides, guys.
Yep. And then I just wanted to add this in here. The tan's the slowest, then the purple, then the white. The white is kind of like if you had a term baby and you just went to Walmart and picked out a newborn flow rate, that's what the white would be. So thinking about kids that have tachypnea or different medical complexities, or your 25-weeker that just turned 34 weeks, we want to start as slow as possible. I don't want to keep seeing how it goes with the faster flow rate and then going back, because that's just setting them up for failure. We don't want to see them fail. We want them to build on the skills that they have and do what they're ready for. So going slow first.
Are the purple, because I'm not familiar with like the purple slow flows, are the purple slow flows and then the yellow slow flows, are those like the same?
So the purple is like a Dr. Brown's Creamy,
Okay.
and the tan is like a Dr. Brown's Ultra Creamy. The gold, the Similac Gold, is supposed to be about the same as the purple, but it's so cheaply made that they're very variable. So
Okay.
some of them will be like a purple and some of them will be like a white. So for a kid that's learning to eat, we always want to go with something that's consistent as much as possible.
Okay, we just have a couple slides to wrap up. Is that okay? Oh, that's me. Sorry. You're good. Okay, so I know a lot that we've talked about today has been about like cardiac and stuff. So a lot of this was geared toward NICU, but also CVICU. All of us work in our cardiac neurodevelopmental clinic. which is once or twice a week where our cardiac infants come back for follow-up and they see nurse practitioner, social work, OT, PT, speech, GI, dietitian, everything like that. So it's a big holistic group where we all follow up and make sure that they're learning and growing and developing to the best of their ability, which is really great has been really great for us to see how this really impacts long term. So it's really hard to see a little baby and think about what it's going to look like in 5 years or maybe even 10. So it's been nice for us to see some of those kids who had a heart transplant 6 years ago here and see where they're at. Oh, they just started kindergarten. What are they doing? So we talked a lot about sensory today. A lot of our kids have sensory defensiveness. They have constantly been poked and prodded and sticked and come out with lots of negative stuff. So they grow up and they don't want to get their hands wet and they don't want to wear certain types of clothes, and parents can't go to the beach because they hate sand and things like that. So thinking about that long term of what we're setting them up for. Delayed motor skills. They spend a lot of time in a bed and restricted with lines and tubes and things. So a lot of them are delayed with crawling, walking, sitting, things like that. So really kind of supporting that. Healthcare related fear. A lot of them come back to our clinic, and even though we have a gym and lots of toys and play, anybody that comes in with a mask, goggles, gloves, puts on gloves, comes to listen to them. Scrubs. It's like an automatic fear and aversion, and they automatically start crying even though there's not any real negative hopes and sticks. Visual perceptual deficits. So they come back and we see a lot of things with their hand-eye coordination, their depth perception, things with their vision that have been impacted because they've been, kind of limited. Executive function deficits, again, so some of those higher order cognitive skills, thinking, planning, organization, memory, things like that. Feeding, she's kind of talked, we kind of touched on that. Aversion, aspiration, ongoing dysphagia, so just consistently being come out and having some of those feeding difficulties. Texture and sensory issues related to feeding, so if you've had a bunch of pokes and prods and sticks and tubes and things and OGs in your mouth, like if somebody comes with weird texture and sensory things, like usually you're going to spit that out and be kind of aversive. And then just developmental feeding delays. Good catches. We have seen people come back in clinic and we have caught things that if our clinic didn't exist and we weren't there with the skilled set of eyes as a whole group of people with nursing and therapy and social work, that these kids would have kept going and been 18 years old and not, been able to do certain things that they should be able to do because they didn't have the right support when they needed it. So catching them and making sure that they're ready to sit down and focus at a desk in kindergarten and first grade, because those are really high level things that they have to do that they may not be ready to do. So some of those good catches that we've had in clinic, I don't know if you want to add anything, but.
This is me.
Okay.
So all this is big picture, so what we do affects them later on, okay? And improving caregiving and having parents help out as much as they can, comfort positioning, all this stuff for the development, okay? Improve milestones too. Because you think that we're saving their lives, but we want to set them up and that family up for success when they go home, okay? No, that's self-explanatory. So if we want to go to the last one, can you just tell us what's one good takeaway you got from this? And then if you have any questions, or one thing you want to take back when you see your patients tonight or tomorrow.
Slowing down, just doing that.
Yeah, and I have to tell myself that sometimes on the regular.
Especially when our census from a therapy point is really busy and I've got 10 people on my list, like I'm often rushing and have to kind of realize that quality is better